Welcome. In this session, we are going to discuss how to examine a pediatric patient and particularly about how to estimate the visual acuity of a very young child. When a child walks into a clinic, we must note that whether the child responds to a silent smile or follows objects in the environment, history taking in a pediatric patient should focus on prenatal and perinatal complications, postnatal issues, achievement of developmental milestones, family history of pediatric eye disorders, and whether parents or caregivers have noted strabismus, nystagmus, or behavioral abnormalities of the patient, such as staring and inattention. A child should be examined in a relaxed environment. The examiner should sit at the child's eye level and maintain eye contact with the child. First, the most important tests to arrive at the diagnosis should be performed because the amount of time the patient remains cooperative can be very limited, and the most threatening test should be performed at the end. And if a child is particularly uncooperative, another visit can always be scheduled. Visual acuity assessment of a child can be done by various methods depending particularly on the age of the child. In recognition acuity, the ability of the child to recognize and name the object displayed to them, such as the optotypes in a Snellens chart, is evaluated. And usually visual acuity of children more than 4.5 years of age can be evaluated by this method. Only the Snellens letters should be used because it has been shown that the Snellens letters are equally easy or equally difficult to recognize by the patient. And use of computerized displays are helpful as they can present alternate charts to avoid memorization of the optotypes on the chart by the patient. For visual acuity estimation, best way of occluding the fellow eye is an adhesive patch to prevent the fellow eye from peeking around the occluder. And in patients with latent nystagmus, instead of occluding the fellow eye, fogging the fellow eye with a plus power lens can be preferable, because the chance of inducing nystagmus and as a result underestimating the visual acuity is less with fogging of the fellow eye than with occlusion of the fellow eye. And if single optotypes need to be shown for a young child to recognize, crowding bar charts as shown in this photograph should be used. Recognition acuity of pre-verbal and pre-literate children in the age group 2 to 5 years can usually be done with handheld cards along with the chart. The handheld cards contain the pictures of the same objects as displayed by the chart, and the handheld cards help the patient to identify the objects displayed on the chart. And the objects can either be familiar pictures or optotypes resembling Snellens optotypes. In the Lia symbols test as shown in this photograph, the objects displayed on the chart are only of 4 types: apple, square, house and circle, and the patient identifies them with the help of handheld cards. The HOTV chart as shown in this photograph and the Landau C and tumbling E charts as shown here. Landau C chart is also known as Landau's ring chart, contain graded optotypes resembling Snellens optotypes. In contrast to the Landau C and the tumbling E charts, the letters used in HOTV chart are vertically symmetrical so as to prevent right-left confusion, which can occur with Landau C and tumbling E charts. Observing fixation and following behavior is another method to assess vision in infants and very young children. In the resistance to occlusion testing, if a child consistently rejects occlusion of one eye but not occlusion of the other eye, the visual acuity in the eye in which the child resists occlusion is significantly better than the fellow eye. Fixation preference is said to be present when a child uses one and the same eye consistently for fixating. This indicates that the eye with the fixation preference has a better visual acuity compared to the fellow eye. Fixation preference testing can be performed for a child with strabismus as well as for a child without strabismus or microstrabismus. For a child with strabismus, the preferred eye or the non-deviating fixating eye is occluded so that the non-preferred eye, that is the initially deviating eye, takes up fixation. Now the occlusion on the preferred eye is removed. If the non-preferred eye maintains fixation even after a blink or a following movement, then fixation preference is absent. But if after removal of the occlusion over the preferred eye again takes a fixation before a blink or a following movement, fixation preference for the preferred eye is present. For a child with no strabismus or microstrabismus, the induced tropia test can be performed to detect fixation preference between the two eyes. In the induced tropia test, a 20 prism diopter base down prism is placed over one eye with both the eyes open. As we have learned, a base down prism placed in front of one eye shifts the image perceived by that eye upwards towards the apex of the prism. So when the prism is placed, if both the eyes move upward, then the eye with the prism is the preferred eye because it refixates on the image shifted by the prism. But if there is no movement of the eyes after placement of the prism, the eye without the prism is the preferred eye, which maintains its previous fixation on the target, while the eye under the prism does not refixate on the image shifted by the prism. But if the eyes alternate fixation, that is, at one moment the eyes are shifted upwards when this eye fixates, and at another moment the eyes are straight when this eye fixates, there is no fixation preference between the eyes. The induced tropia test is repeated with the prism over the other eye, and if the child prefers the same eye both the times, that eye is said to have fixation preference. And no fixation preference is said to exist if there is alternating fixation during each test, or the child consistently preferred two separate eyes during each of the tests. After fixation preference for one eye has been determined, to evaluate how well the non-preferred eye maintains fixation, the prism and occluder is placed over the preferred eye, and after the non-preferred eye takes up fixation, the occluder over the preferred eye is removed and the behavior of the non-preferred eye is observed as regards loss of fixation before or after a blink or following movement. CSM evaluation, standing for central, steady and maintained, is helpful for describing and grading fixation ability of an eye with the other eye occluded. The fixation ability of an eye can be central when the fovea takes up fixation of the target, or non-central or eccentric when a non-foveal region of the retina takes up fixation of the target. Fixation of an eye can be steady when it does not move while fixating, or non-steady when it moves even while fixating. And the fixation of an eye can be graded as maintained or non-maintained by observing the length of time that eye can maintain fixation on the same target after removal of occlusion from the fellow eye. If the eye being tested can maintain fixation only for less than 1 second following removal of occlusion over the fellow eye, fixation preference with the fellow eye is said to be very strong. And if the eye being tested can maintain fixation for 1 to 3 seconds following removal of the occlusion over the fellow eye, fixation preference with the fellow eye is said to be strong. But if the eye being tested can maintain fixation through a blink or a smooth pursuit movement after removal of the occlusion over the fellow eye, fixation preference with the fellow eye is said to be weak. And if fixation alternates between the two eyes, there is said to be no fixation preference. Children with a strong fixation preference for one eye are likely to develop amblyopia in the other eye. Preferential looking tests can be used to quantitatively assess visual acuity in infants and very young children, that is, children around 2 years of age and younger, and it is based on the principle that infants tend to view a pattern stimulus instead of a homogeneous area. So cards with objects are shown to the child, and the examiner observes whether the child persistently fixates on the object or randomly looks all over the card. Preferential looking test can be done with cards having grating patterns such as stellar acuity cards, and in grating patterns there are black and white parallel lines with the separation between the lines varying between the cards. And the Cardiff acuity test have pictures called vanishing optotypes. These pictures are called vanishing optotypes because the mean luminance of these pictures are similar to the luminance of the remainder of the card, and the child can only use his spatial resolution ability to detect the line used to draw these pictures, and so the thickness of these lines can be used to determine the visual acuity of the child. It is important to note that preferential looking tests estimate spatial resolution ability and not recognition acuity. The Taylor grating card or the Cardiff vanishing optotype card with the finest lines which the patient fixates preferentially corresponds to the spatial resolution ability of the child and indicates his or her visual acuity. With this method, visual acuity is usually found to be 6 by 120 for a full-term newborn and reaches 6 by 6 level by 18 to 24 months of age. Response on preferential looking test depends on attention, motor response of eye and neck muscles, and intact visual fields. Since preferential looking tests gives the resolution or grating acuity instead of recognition acuity, it may underestimate the extent of loss of visual acuity in an eye with amblyopia. In infants, eyelid retraction or the stare response when room lights are dimmed indicates good visual function, and so does blinking on exposure to bright light. When an examiner holds an infant and rotates the infant horizontally, the examiner will observe that the horizontal spin induces a nystagmus in the infant, with the fast phase of the nystagmus opposite to the direction of rotation during the rotation and in the direction of rotation after the rotation stops. So when an examiner holds an infant and rotates the infant in this direction, the examiner will observe the infant to have a nystagmus during the rotation, with the fast phase of the nystagmus in a direction opposite to the direction of rotation. After the spin stops, the nystagmus stops within 5 seconds by fixational dampening in an infant with intact visual system. But the nystagmus persists for 15 to 30 seconds in a child with poor vision before mechanical dampening stops the nystagmus. If there is no nystagmus or a rapid phase of nystagmus on spinning a very young infant, it indicates that saccadic and pursuit movements have not yet developed in that infant, and so fixation and following tests will give inaccurate results in that infant. Evaluation of visual acuity by detecting optokinetic nystagmus is not a preferred technique of assessing visual acuity in young children. After discussing evaluation of visual acuity in children, we will now briefly discuss the other examination techniques in this population. Pupillary light reflex can be difficult to determine in very young children because of a small pupil size in these patients, and also because these patients are not able to control accommodation, and we know that meiosis accompanies accommodation in the near reflex. In infants, a magnifying glass helps in detecting the small amplitude pupillary response in a small pupil. Paradoxical pupillary response, that is dilatation of the pupil on direct illumination, can occur in certain conditions such as Leber's congenital amaurosis, congenital achromatopsia, optic nerve hypoplasia, and congenital stationary night blindness. Congenital or infantile nystagmus suggests severe bilateral pregeniculate lesion, but nystagmus is usually absent in cerebral visual impairment and in patients with unilateral visual loss. The Bruckner test is said to be an important tool for screening ocular abnormalities in young children. In a dimly lit room, a direct ophthalmoscope is projected from a distance of 1 meter to get a reflex simultaneously from both the pupils. In a normal subject, both the pupils appear to be uniformly illuminated in intensity and color, and with foveation of the reflex becomes equally dim in both the eyes of a normal subject. But in a patient with strabismus, the reflex from the deviated eye appears to be brighter than the reflex from the undeviated eye. With media opacities such as cataract and vitreous hemorrhage in the eye, the reflex is not observed, and in refractive errors, a peripheral crescentic reflex, as shown here in this photograph, is observed. In myopia, the peripheral crescentic reflex appears on the same side of the center of the pupil as the light projected from the direct ophthalmoscope, and in hyperopia, the crescentic reflex appears on the opposite side of the center of the pupil as the light projected from the direct ophthalmoscope. Ocular alignment and ocular movements we have discussed in detail in previous sessions. In this section, visual fields can be grossly tested after 4 months of age when fixation develops in a child, and with the child fixating on a central target, a peripheral target is brought in from a quadrant, and if this induces a saccade from the central to the peripheral target, visual field is considered to be grossly normal in that quadrant. Confrontation visual field assessment, which we have discussed in the section on neuro-ophthalmology, can be done in older children who can identify and count fingers. Anterior segment examination can be done in a young child with the help of a portable slit lamp or loupe or a 20 diopter lens used as a magnifying glass along with the indirect ophthalmoscope. To examine the anterior segment, the 20 diopter lens is held much closer to the eye than the distance it is held during indirect ophthalmoscopy. Fundus examination of a young child can be done with an indirect ophthalmoscope after reducing the illumination level of the indirect ophthalmoscope. And for hospitalized patients, if pupillary dilatation is required, the primary care team of the patient should be notified about pupillary dilatation being done. Cycloplegic refraction is required in patients with abnormalities in binocular vision and or ocular alignment, particularly those with accommodative esotropia. We will be discussing about accommodative esotropia in the next session. To induce cycloplegia with cyclopentolate, 2 drops of 1% cyclopentolate are instilled at 5-minute interval. Cycloplegia starts 30 to 60 minutes after application of the drop and persists for 1 to 2 days. Cycloplegic refraction with atropine is more efficacious and so preferred in infants, in patients with accommodative esotropia, and in patients with dark colored iris. For cycloplegic refraction, atropine 1% eye drop or eye ointment is applied once daily for 3 consecutive days, and cycloplegic refraction is done on the 4th day. Cycloplegia following atropine application starts 45 to 120 minutes later and persists for 7 to 14 days. With either cyclopentolate or atropine, mydriasis starts before and lasts longer than cycloplegia, so presence of mydriasis does not ensure that concomitant cycloplegia is also present. Tropicamide, particularly in children, and phenylephrine do not cause adequate cycloplegia and so should not be used for cycloplegic refraction. Side effects following application of cycloplegic eye drop or eye ointment is more common with atropine. Local side effects include conjunctivitis with redness of eyes, edema of the eyelids, and periocular dermatitis. Systemic side effects occur particularly in children with light-colored iris and includes fever, tachycardia, dry mouth, dry skin, urinary retention, constipation, and delirium. Most of these symptoms are due to the anticholinergic effect of atropine. And refraction following cycloplegia can be done by either strict retinoscopy or automated refractometers. Dynamic retinoscopy measures the ability of a child to accommodate a normally accommodating emmetropic subject or an ametropic subject with full refractive correction for distance in place will have a neutral retinoscopic reflex both when retinoscopy is done from distance with the subject fixating on a target at distance, and subsequently when retinoscopy is done from near with the subject fixating on a target at the same distance from the subject as the examiner's distance from the subject. Hypoaccommodation is seen in patients with Down syndrome and cerebral palsy. Visual evoked potential by the sweep method can objectively quantitate visual acuity in infants and very young children. In this technique, VEP response to a series of grating charts is assessed. As the spatial frequency of the grating chart becomes higher, that means the lines of the grating become narrower and more closely spaced, the amplitude of the VEP response decreases till a threshold spatial frequency grating is obtained, which represents visual acuity of the subject. In this technique, usually 10 to 20 gratings of increasing spatial frequency are sequentially shown within 10 seconds. Since the waveform in sweep VEP changes between 1 and 6 months of age, the obtained waveform should be compared with an age-matched waveform. The grating resolution acuity obtained by this SWIP VP method are usually better than visual acuity estimates obtained by the preferential looking tests, which, as we may recall, also gives visual acuity estimation based on spatial resolution ability. With full-term newborn infants normally demonstrating 6 by 60 visual acuity, with SWIP VP method reaching 6 by 6 levels by 6 to 12 months of age. If we recall, with the preferential looking tests, visual acuity estimates are usually 6 by 120 in a normal full-term newborn, which reaches 6 by 6 level by 18 to 24 months of age. ERG testing can be helpful in a patient with poor vision, but with normal ocular examination finding. Poor vision in an infant is usually diagnosed after 3 months of age, the age by which fixation normally develops. Presence of nystagmus and or abnormal pupillary reflex suggests severe pregeniculate lesions as the cause of poor vision. And in a patient with poor vision, if pupillary response is normal and nystagmus is not present, the poor vision can be due to either cerebral visual impairment, in which case it is usually associated with other neurological signs, or can be due to delayed visual maturation, in which case visual behavior normalizes usually by 6 months of age. So what is important is we have to note presence of nystagmus and or abnormal pupillary reflex in an infant with poor vision. To recap the salient points, recognition acuity with Snellens charts or with crowded single optotypes is possible with a child above 4 to 5 years of age. In a pre-literate or pre-verbal child between 2 to 5 years of age, recognition acuity can be taken with picture charts such as the Lear symbols chart or optotype charts such as HOTV, tumbling E or the Landau ring chart, along with handheld cards for matching. For infants and very young children, resistance to occlusion of either eye, fixation and following behavior, fixation preference with the CSM method, and preferential looking tests with grating cards such as the Taylor acuity cards or vanishing optotypes with the Cardiff cards can be used to assess visual acuity. Bruckner red reflex test can detect strabismus, refractive errors and media opacities. In an infant with poor vision, nystagmus and pupillary abnormalities suggest abnormalities in the anterior visual pathways. But in a child with poor vision, if nystagmus is not present and pupillary reactions are normal, the poor vision is due to either cerebral visual impairment or due to delayed visual maturation. Pupillary reaction can be difficult to detect in a young infant because of the small size of the pupil and the small amplitude reaction of the pupil to light. Cycloplegic refraction is recommended in infants and in children with strabismus. Thank you for listening.